Good evening, everyone. Today I'm going to talk something about NT-proBNP. This is gaining momentum. Everyone wants NT-proBNP, cardiac fitness, all these things are coming out. Before that, I would like all of you to subscribe and listen to my channel, YouTube channel, Pain Free Partha. So what is this? Heart makes BNP. That's very important. Because it was first found out in porcine brain, it was called brain natriuretic peptide. Now, because now we know that it is not now brain, it is mainly from the heart, we cannot change it. So they thought atrial natriuretic peptide is ANP and we have BNP. So that is why it came brain natriuretic peptide to B natriuretic peptide. This is what is the difference. Because it was found in the brain of porcine first. It was called as brain natriuretic peptide. Then it became B natriuretic peptide. This is what is BNP. Now you can see pro-BNP, furin, anti-pro-BNP, N-terminal, inactive portion. You can see this is the inactive N-terminal portion of the pro-BNP. This comes here. That is why it is called anti-pro-BNP. Even though there are N-terminals here, the original molecule's N-terminal is here, which is inactive, and this BNP is active. How it comes and goes? Pre-pro-BNP, pro-BNP. This is the cardiac myocyte, and this is the blood. Pro-BNP comes, anti-pro-BNP comes out, BNP. Here there is an exchange, and anti-pro-BNP is high. It basically is coming from the cardiac myocyte. In the normal state, the atrium also gives off some BNP. And only in patients with myocardial stress, the ventricle starts to produce BNP. So it acts on distant tissues. So now we have an atrial stretch, LVDP is increased, BNP is produced, and these BNP causes a natriuresis because it's a natriuretic peptide. Natriuresis means sodium loss associated with water loss. Then there is a decreased BP. It also causes vasodilation and it also causes decreased renin, thereby decreased aldosterone and decreased blood pressure. This is how it acts. Now, what is the normal value is 125 picogram per ml for adults and up to 450 can be up to this thing. But for ease of interpretation, we don't confuse this thing. 125 less than 500 or more than 500 in some people. What is practical, I will tell you later. The plasma concentration of NT-proBNP and BNP is approximately equal in normal controls. So, NT-proBNP plasma concentration is around 6 times higher because relative changes may be explained in shifts in cardiac secretion and clearance mechanism. I'll come back again. But NT-proBNP is costing around 800 rupees in many of the laboratories. The half-life of BNP is 20 minutes and NT-proBNP is 120 minutes. That is why we measure NT-proBNP and there are less fluctuations because you see the half-life is 2 hours whereas BNP is only 20 minutes. We can measure both but this is more stable, less fluctuation. That is why we want to measure NT-proBNP. So bedside blood test, it can come in 15 minutes. But sometimes a falsely high B natriuretic peptide may be in patients without heart failure also. Now we know it is usually high in cardiac failure. What are the other conditions in which the NT-proBNP is high? It may be high in renal failure. It may be high in hypertension. It may be high even pulmonary hypertension. COPD, that is very important. Sometimes we know that this patient is the dyspnea. We want to know echo is normal. We want to know the cardiac involvement in a patient with COPD. And then we do this NT-proBNP where it may not be useful because even in COPD, it may be high. infarction, atrial fibrillation, acute coronary syndrome, myocarditis. There are other conditions like old age, cirrhosis, hyperthyroidism, and chemotherapy. So many causes of high NT-proBNP other than congestive heart failure. Now we know ARNI. Neprilysin inhibitors can inhibit conversion of proBNP to BN. So, CCF with early CKD. What we do is angiotensin receptor blockers with neprilysin inhibitors. What they do, neprilysin inhibitors, they cause diuresis, they cause natriuresis because neprilysin is against this. So we have a neprilysin inhibitors. What is a neprilysin inhibitor? We have a famous combination of sacubitril valsartan. This is being given in many patients with cardiac failure, especially early CKD. What you call valsartan is an ARB, and your sacubitril is a neprilysin inhibitor. So we have ARNI, that's what angioreceptor blocker with neprilysin inhibitor, ARNI they are called. So there are numerous drugs, that is what is called sacubitril and valsartan. So we want that to be there. So it's not new. So why I am telling about this is this sacubitril valsartan may cause slightly increased proBNP. So this is patients will receive this drug, especially when a patient with heart failure. So this drug itself will cause an increase in NT-proBNP. That is why we should know whether the patient is on ARNI or not. Yes, NT-proBNP, we thought it is new. No, it is not new. Here you can see 2003, a new diagnostic, whether this patient has got a normal or a reduced ventricular systolic function. B-type are markers of myocardial stress. You can see this is, they are markers of myocardial stress. We should clearly know again, I am telling you, BNP is active. It causes decreased BP, it causes natriuresis, it causes water to go out, bad, aldosterone, all these things. But pro-BNP doesn't have this much of active actions in the body. So it is slightly inactive. Now, what are the actions, indications of watering? Sometimes we may think that this patient is a heart failure, but this patient is not classically presenting. He's having nocturnal cough. He's having some nocturnal dyspnea. He's having vague fatigue. He's having breathing difficulty plus ECG echo is normal. All these things, confusion. So we can order in these patients NT-proBNP. Now there are certain facts. I'll tell you. Brain natriuretic leads by ventricular myocytes in response to wall stretch, myocardial IPN, ischemia, and fibrosis. Splits into inactive terminal, which decreases SVR. Elevated BNP may be detected even in patients with non-cardiac illness. Now we see BNP is increased in myocardial IPN, but BNP is also increased in renal failure. Elevated pre-op BNP levels are associated with increased risk of postoperative deaths and major cardiovascular events. This is one. Now you see the prognostic value of, see here, systematic review and meta-analysis. What they have told is there is similar. Elevated NT-proBNP, this is about 2179 patients. This is slightly contradictory. Measurement of preoperative adds incremental prognostic value. This is what is very important. Now, so many cardiac risk indexes are there. We have RCR, Goldman risk index, all these things. If you have NT-proBNP level high, the strategizing or stratification of where the risk is what they say is better if the NT-proBNP is high in such patients. Overall, what happens is it's only a delay or it's only cancellations or a lot of opinions because it is not going to change the practice. It is may be causing delay, cancel, or it may increase opinions. Most myocardial injuries are asymptomatic. If the preoperative NT-proBNP, can we do a daily ECG surveillance? It is not possible. So what they call is MINS, myocardial injury after non-cardiac surgeries. They are asymptomatic. That's what they say. If you think the preoperative NT-proBNP, can we do a daily ECG? No. Pre-op NT-proBNP levels, do they improve our care of high risk? There is not clear at all. Now we have one more thing. Preoperative, there's one study which tells in 2022, we have a patient with low ejection fraction. We have a patient also with NT-proBNP. What they say is, these patients, after non-cardiac surgery, they go on to have acute kidney injury. Means these are two independent predictors. If NT-proBNP is high in a non-cardiac surgery, then there is a chance of acute kidney injury. If an LVF is low, LVEF is low, then there is an independent predictor of acute kidney injury after non-cardiac surgery. Understand? So LVEF is low, acute kidney injury after non-cardiac surgery is more. Pre-op NT-proBNP is high, then acute kidney injury after non-cardiac surgery is high. This is what is the thing in this study. Now there is one more thing, so stratification is really it is useful. There is one study which tells, but it is in 2011. Both it says even echo or NT-proBNP both cannot strategize. Because NT-proBNP even in young healthy adults undergoing non-cardiac surgeries. For example, if you do an appendectomy under spinal anesthesia and you take an NT-proBNP level post-operatively, it is raised, completely unevenful. That is one major problem with NT-proBNP. We should also know preoperative is it next steps to clinical practice. What type of surgery prior? What was the surgery done? For example, he has undergone a stent. He has undergone a CABG. What type of surgery now? Hernia, appendix, or mastectomy? What is the cutoff value? He said there is one study which tells more than 326 of NT-proBNP value. Is it sensitive or is it specific? All are questionable according to this next steps to clinical practice. NT-proBNP, what they say is, now he is reporting a self-functional capacity. I am not able to go upstairs. I am not able to go and come back after passing to the restroom in the night. So this is self-reported functional capacity. This is better or NT-proBNP is better. So what they say is, in this also self-reported functional capacity is better than NT-proBNP. So that's clinical applicability of NT-proBNP over a self-reported functional assessment. Now here there is a point. Some patients may come for total knee replacement. Self-reported functional capacity, how will you do? He'll be lying down. Some patients will be with diabetic foot. Some patients will be with having some fracture for old fracture. They will not be moving. So self-reported functional capacity is not possible. Then you think whether these patients can undergo NT-proBNP. Now what all we are told is about non-cardiac surgeries. Now we go to cardiac surgeries. Preoperative plasma NT-proBNP, high individual variability. Okay. NYHA classification, EF, pulmonary artery pressure, left ventricular and diastolic, AF, preoperative plasma creatinine, troponin levels. All these things are also plus NT-proBNP to find out post-operative outcomes. Post-op NT-proBNP can serve as an objective marker of post-op dysfunction. Comparison at cohort level. Tool for study purpose when an unbiased assessment of prevention or treatment of HF is desired. For children after congenital heart disease, now adult cardiac disease, yes, there is some problem. If a NT-proBNP is high, they are more prone for myocardial dysfunction. If the NT-proBNP is high, it goes along with atrial fibrillation, congestive heart failure, low LVF. All these things are some problem. NT-proBNP is also some problem. In pediatrics, yes, if NT-proBNP is high, they can predict prolonged ventilation, prolonged ICU stay, and possibly increased inotropic requirement. Strongly correlated with postoperative complications. Early outcome after cardiac surgeries, especially when you don't have an echo here. Urgently, echo technician is not present or some machine problem. Now you take an NT-proBNP level and see, then you can decide on your inotropes. Your inotropes, yes, this may be needed because your NT-proBNP is high. Now, what is the message? There is no rule or no recommendation, pakka recommendation for doing a preoperative NT-proBNP. It is preferable in certain cases of undiagnosed dyspnea. For example, patient is dyspneic, RS is clear, no wheezing, nothing. ECG echo is normal, the patient is still dyspneic, every other thing is fine, yes. Or sometimes the echo shows a mild diastolic dysfunction. There is a problem. Here you have an undiagnosed dyspnea. Where is only DD1? Yes, in this case, go for an NT-proBNP and think and try to correlate your undiagnosed dyspnea with diastolic dysfunction grade 1. COPD echo shows left atrial dilation sometimes. Then your NT-proBNP will be high. Moderate AS. If your NT-proBNP is high, we can give ACE inhibitors. Otherwise, in AS, this may not be very good drug. Now we take a patient with bilateral knee osteoarthritis. Already I have told self-reported functional capacity or the other person, for example, his son telling that this will, my father will go walk around or all these things is not possible because it's got a bilateral osteoarthritis. ECG and echo are normal, he may not need. But as an echo is showing diastolic dysfunction, what is the stage of dysfunction? Or if the patient is having some symptoms on rest or minimal movement, yes, then we can try doing NT-proBNP and have a gauge of these things. Now we'll go to another case. Rheumatoid arthritis for non-cardiac surgeries. ECG echo normal, CT chest is normal, but dyspnea is out of proportions. We will prefer if the NT-proBNP is high, then give ACE inhibitors and diuretics are one or two cases, and then take up for this non-cardiac surgeries because it's not an emergency. Think about dyspnea is out of proportions, ECG echo normal, NT-proBNP is high. Give ACE inhibitors, give diuretics for 1 or 2 weeks, then take up the case. What is high NT-proBNP? Then there is a doubt because its normal is 125. Some say 326. We would suggest any correlation above 1000. Then there is no clear evidence for this, but definitely if the NT-proBNP is above 1000, this patient will be better off with diuretics, and immediately in 2 weeks to 3 weeks, the NT-proBNP level comes down to 100 to 200. We have two studies going on here between pregnancy-induced hypertension, echo, NT-proBNP levels and clinical features, and with coronary artery disease, echo, NT-proBNP with clinical features. The problem is diuretics and ACE inhibitors. They can cause hypovolemia and electrolyte imbalance. These two things are very important. Just because we have measured some NT-proBNP and giving ACE inhibitors and diuretics as anesthetist, we should not forget the problems of these drugs like hypovolemia and electrolyte imbalance. We can also give beta blockers and diuretics in certain cases. So why do we need? We should be very clear that NT-proBNP is not going to be the answer for everything. Yes, it gives a clinical clue in undiagnosed dyspnea. It gives a some clue in patients with mild diastolic dysfunction with disproportionate dyspnea. It gives a clue when echo is abnormal and we cannot find out the functional capacity of the patient. Furthermore, we should see what are the drugs he is giving, especially army. This itself can slightly increase the BNP. Another point is post-operatively, if we take a pro-BNP and it is high, we will not know because pro-BNP itself may increase with normal non-cardiac surgery in healthy patients. So we have a baseline pro-BNP levels and then we have some doubts about means then you take ECG and your anti-pro-BNP levels. Thank you very much.